Look, I also would like to acknowledge the traditional owners of all the people, all the lands upon which everyone's listening to from, and to give my respects to their elders, past, present, and emerging. And I'd like to thank any Indigenous people who are present here today for attending. Look, it's been my great joy to be part of the team that developed the guidelines we're going to talk about today. They are an incredible resource, an incredibly rich resource. And it'll take the whole hour to understand what you can get out of it for your patients. Let me give you a bit of history. You'll see that the Menzies is recognised on this slide, and that is because the Menzies has had a very long interest and deep interest in the treatment of otitis media. The CRE from the NHMRC for ear and hearing health that was awarded some years ago now led to the funding that allowed for the development of this revised version of the guidelines, because there were previous guidelines in 2010. Professor Amanda Leach from Menzies headed up the CRE and has been the driving force for the development of the app and the guidelines. I really want to thank her for her leadership, including the donation of her slides, which I have thought were probably many of which were the very best way we could present this information to you today. So thank you very much, Amanda. But this has been a truly national enterprise. It involved weekends and weekends of people from different parts of Australia, from different backgrounds, surgeons, audiologists, scientists, getting together and nutting out how to solve this problem of usable and practical guide to the treatment of otitis media and how we would present this information. And so that's a journey that we are going on today. So I will now just find how to advance my slide. Find the right screen here. Oops, here we are. That's better. Right. So we've had our acknowledgement to country. Now, for any of you that haven't actually yet downloaded the app, I suggest that you do, because later on in this talk, we will be going through how to use the app, and I'll be taking you through the home screen of the app and how to find your way to various bits of information. You can click on this if you wish to get access to the guidelines. There are other ways to get access to the guidelines, the simplest being to go to the App Store on your phone and to look at the otitis media guidelines, and you'll find them there as well. But let's a little bit of background on otitis media. I'm making an assumption that most people here know a fair bit about otitis media already, and that most people here on this particular webinar are probably treating this condition. I think this articulation is a very, very good one, that otitis media in Aboriginal infants occurs early, is persistent, is bacterial. And I think it's really important. We'll come back to that time and time again. And it's often asymptomatic. And that just last year, 71% of infants may have chronic otitis media by the age of 7 months and meet the needs for specialist referral in some parts of Australia at least, and particularly in the Territory. So staggering numbers when you stop to think about it. The other main message to go away with is that if an Indigenous child has otitis media or a type B tympanogram, because sometimes, it can be difficult to tell whether a person has otitis media or not, the chances are they have a hearing loss. So that more work from Menzies has shown that 75% of children with any form of otitis media or a type B tympanogram will have a hearing loss. And that can be contrasted by the finding of a normal or type A tympanogram, where the vast majority of children have normal hearing. What this highlights is that the tympanogram is a very, very powerful means of determining whether there is middle ear disease, and therefore whether the person in front of you is likely to have otitis media. And we will come back to this key point. Even more concerning is that 40% of those 75% actually had moderate which is actually very disabling hearing loss. So, I mean, a few words on how chronic otitis media and disabling hearing loss impact Indigenous Australian children. Well, there's a really much higher vulnerability for kids entering school with otitis media. There's poorer school attendance. There's poorer NAPLAN results. There's an increased risk of substantial child maltreatment. And there are increased numbers of children with interaction with the youth justice system, and incarceration is more likely. And that any child with chronic otitis media in early childhood has an increased risk of vulnerability at entering school. So these are really significant things. So what can be done about it? What needs to be done about it? Firstly, obviously, to prevent otitis media. And how can this be done? Well, some things we know work is to reduce crowding and hygiene, to build resistance, vaccines and breastfeeding. The next obvious thing to do is to prevent the progression of otitis media and its chronicity if we possibly can. And the real key to that is to treat otitis media early and appropriately. Next, we need to prevent the disadvantage associated with otitis media and hearing loss, and that is with hearing rehabilitation. So where do the guidelines fit in? Well, the guidelines fit in here. And they've really had some principles behind them that come back time and time again. And that is to give improved access to the timely and important and up-to-date information, to increase confidence of healthcare professionals in using this information, and to increase the uptake of evidence-based practice. So how can you actually, what more about the guidelines? Well, you can see here the original guidelines from 2001, which were then substantially elevated in 2010 to a series of guidelines of which I was again privileged to be part of the steering committee. And then it's been 10 years. And of course, it took a fair bit of funding and hours of work to update these guidelines. And this has all come, as I said, largely through the work of Menzies, through Peter Morris, who you see there, and through Amanda Leach, but really with national input and passion from many, many other people. But now you can get it on your phone, which is what we see here on the right. And this is what the home screen looks like. And I trust that this is where you will be, all of you, following this talk right now. How can you get it? We've talked already about downloading it from the App Store or onto your PC. You can get it from the CRE website. There's information there about the guidelines. You can get it in various forms there. You can download the PDF, which is more the formal kind of book-like document. And also it has links to the online resources. This is what the real book looks like, and you can see there what can be done. But now getting down to the actual guidelines in 2020, and we'll be talking a lot about what is different and what's new in these guidelines. And these are the new changes. Firstly, we have used the GRADE approach, which I'll talk to later, which is a standard evidence-based medicine approach to ensure that what is presented in these guidelines is informed by the evidence, is incredibly well targeted and thought through and articulated. So this also means we've appreciated that not all Indigenous kids live in the same environments, and that some Indigenous children will have, be it either higher or lower risk of chronic otitis media. Now, that's really important when you come to think about guidelines that might have national significance. And it's appreciated that someone working in the middle of a large city may be seeing Indigenous children that have quite different social circumstances to those just serving remote communities. So we have considered throughout where relevant the risk level for the child, and have different guidelines according to that. We have new guidelines on surgery. As you'll probably know, tympanostomy tubes, otherwise known as grommets or ventilation tubes, are often used to treat otitis media, but it is also appreciated that in Indigenous kids, otorrhea often has been an accompaniment, and the management of the otorrhea is important for keeping the child hearing. We've also highlighted for you some priority conditions for children's services so that you can have your radar up immediately to know which children to look out for. About treatment, there's some strong guidelines and recommendations about the use of antibiotics for otitis media with diffusion in high-risk children. Here, high risk, as we'll come back to and discuss later, is children where you think that they are in a situation where they have a high risk of developing chronic otitis media, which the World Health Organization determines as a greater than 4% risk. And that's largely an epidemiological kind of determination according to where the child is growing up and practices. Of course, one can't really separate out the child's Indigenous background and other risk factors that might relate to that or be associated with that from the demographics, but one has to, as a clinician, at least try. Another new addition here is the use of azithromycin for the treatment of acute otitis media, particularly where there's a risk that children may not there may be difficulties in ensuring compliance to the treatment or where refrigeration is not available. Another major change, which you'll see throughout and we'll keep coming back to, is the concurrent referral to both audiology and ENT referrals, because it's very clear to all of us working in the space that the sequential typical medical model of observing, watch and wait, and if a child has ongoing problems, refer them on for either audiology and then from there to ENT, was introducing significant delays in systems where even to get one of those services is too long. So we have decided to recommend most of the time concurrent referrals. The other major change in referrals is that for chronic suppurative otitis media, which I'm sure you will be aware is when there is a chronic discharge from the ear in the presence of a perforation of the eardrum, that we now recommend referral to ENT immediately that this is recognised as chronic otitis media, and we'll come through what that might mean a bit later. In terms of treatment, there is, we believe, sufficient evidence to suggest autoinflation of the middle ears by using balloons or by Valsalva in the treatment of persistent otitis media with diffusion. There's been a lot of changes to hearing loss in this assessment and management. And particularly we have aligned the definitions of moderate hearing impairment to those of the World Health Organization definition of disabling hearing loss in children. Now that's actually quite important because of course these definitions vary from jurisdiction to jurisdiction, but the World Health Organization is probably the best benchmark that we could have thought of. And what you'll be learning about as we go through the next part of this is what's on that app if you have it on your phone and how to use it when you have a child in front of you. So when we have so much information, we try to distill this information in several ways that we trust will be very useful to end users. And one of these is some key messages for primary healthcare providers. And we're just going to run through what they are because they are guiding principles that you will see throughout. And that is that it's really important, firstly, to let the families know about the importance of hearing for learning culture and language. The second one is to let the families know that severe otitis media can be prevented and improved, and that one doesn't have to accept that if their child has this problem that nothing can be done. And so there's practical advice on what can be done within the community at a broader level than just the individual family. When we come down to individual families, we want to empower them to know that there is an importance of attending the local health clinic as soon as possible when a baby or child has pain, ear pain or discharge. We want to empower families to know that it's the right thing to ask that their children's ears are checked, even when the child appears well. And this will, of course, mean that we have a greater pickup on the more silent aspects of otitis media. There are now recommendations for antibiotics, amoxicillin being the default position, unless azithromycin is considered to be the best option for particular circumstances. For acute otitis media with perforation, and for children with acute otitis media without perforation, if they are at a high risk of developing chronic suppurative otitis media, which is greater than 4% risk. There's also recommendations about regular review and how long this should be continued to give you some very clear and specific advice. We are now believing or suggesting that chronic otitis media should be diagnosed when a child has a chronic ear discharge for more than 2 weeks. Now, that's quite a change, really. It's going to trigger referrals and the like at a much earlier stage in your engagement with the child's care than what was probably previously considered. There's advice there on what is appropriate management for chronic serious otitis media, which includes regularly cleaning up the ear with ear mopping or syringing, and the application of topical antibiotics and when that's indicated. And it's also our recommendation that children with persistent bilateral otitis media of any type for greater than 3 months should have a hearing assessment and be managed with referrals as appropriate. Another part of the education piece is to let families know if there is disabling hearing, about the benefits of improved communication strategies and the options for surgical interventions such as grommets and hearing aids. And also general education to families about how children learn to talk, the fact that they're listening to language, and there are resources there to help educate families. And finally, that the aim is that this knowledge to help manage, to give the families enough knowledge so that they can manage the health care needs and ear care needs of their own children, and that the app provides resources to help with that. So that's one way of looking at the guidelines from the top level, and some of the things I've gone over there are the major changes for any of you that work in this space. But of course, another way of thinking about this is to think about the various conditions and ways in which otitis media is presented. So we've given you summaries for all the various types of presentation of some of the factors that should be considered in each case. Note that here on this slide, you'll see that even when there is a normal ear, there's a job to be done with respect to hearing, and that is about family education. And family education is one of the constant features throughout these apps. Consider there the persistent bilateral otitis media or unilateral otitis media. So we have all of the people that need to be involved and the recommendations concerning their engagement and the various options summarised here. Similarly, for otitis media without perforation. Now, look, you might, some of you wonder what exactly this is. I think it probably is worth dwelling on, and that is it's considered or acknowledged that Indigenous kids, sometimes they have what is more a purulent effusion of the middle ear rather than classic otitis media with effusion. Classic otitis media with effusion is essentially a non-infected middle ear, but it seems to be the case that in many Indigenous kids, what is behind the eardrum is certainly infected. So then, of course, it may perforate. And there's a significant difference between what one sees in viral otitis media, which is probably what a lot of GPs see, and where much of the idea about the watch and wait principle of not prescribing antibiotics comes from. But when there is actually an infected effusion in the middle ear, which is the otitis media without perforation, this can grumble on for a few weeks in Indigenous kids, and there is a much greater chance that there is actually pus there. And in which case, the role for antibiotics is very, very different than what it might be for a typical child who might have a red eardrum and some otalgia with viral otitis media. There are different guidelines again for recurrent acute otitis media. We have guidelines for the otitis media with perforation. And here the critical thing to understand, and we've got some visual guides here, is the size of the perforation. As will become clear later, if the perforation is too small, drops won't work. And so essentially we are suggesting that if the hole needs to be bigger than 2% before antibiotic drops have a role. And if the perforation is smaller, then antibiotics are the only thing that are going to work. And then finally, the treatment options for chronic suppurative otitis media. Now, we have some new guidelines as well. So we have new guidelines on what we call TTO, or that's what you might see throughout this, and that is tympanostomy tube otorrhea. These are brand new guidelines. They are there because of the high incidence of discharging ventilation tubes in children that have this problem, but also because the treatment can really help. So there is family education relating to that. The medical treatment is to clear the pus from the ear canal with ear spears or syringing at least twice daily, and to use ciprofloxacin ear drops, 2 to 5 drops 2 times a week, so 2 times a day for a week after the cleaning, and then to apply tragal pumping to get the drops through the grommet. And then to review these children weekly. And of course, if that doesn't work, it's going to turn into an ENT referral if this discharge continues for 4 weeks, or if it occurs intermittently for 3 months. So that's another way you can use these guidelines, just to refresh your general knowledge about the overall way in which otitis media can be treated. Another thing that we've introduced here that is, and one of which is new, is to provide a list of priority children who you should really have your radar up for whenever they present. And that is because there are some groups of children, and we've highlighted them here through here, we'll actually go through these individually, that have a much greater risk of very avoidable adverse long-term outcomes if their management isn't prioritised. And the first thing is any child under 3 years of age with discharging ears. Now, the main thing here, of course, is that a child of this age is still learning to speak and developing language. And so they are considered to be a really high priority. The second, here the most important thing is to consider appropriate use of antibiotics. And the second the second risk factor is children under the age of 10 who have hearing loss of 30% or greater, and who already have speech-language communication problems. Now, look, many of you probably see many of these children. We've provided some guidance on how these children should be dealt with in these guidelines. The third group of children are those aged 3 to 10 who have discharging ears. Not quite as high a priority, you might say, as the children under 3. But here, the idea is to have long-term support, to support long-term topical antibiotic treatment, and to have appropriate audiological management, and to have appropriate ENT referrals. The next group, and why are these children at risk, is because they're still at school and their hearing will be impaired because of the discharge. The next one is the children aged under 10 who have persistent otitis media with tympanic membrane abnormalities and hearing loss of greater than 30% in the better hearing ear. These children are going to need significant help with communication strategies that we will go through. And new to these guidelines is that children aged 0 to 16 who are at risk of chronic ear health problems, who reside in high-risk populations and who haven't had a documented ear assessment in the previous 12 months or have missed their ear health check previously. And the idea here is to make sure that you actually have documented and looked at their ears to ensure that the silent aspects of otitis media are not being missed. The other ways you can access this information is through some high-level summary of the guidelines that was published in the MJA. And here we see, once again, of course, Amanda Leach and Peter Morris represented, but there is national representation in the people that contributed to these apps. So now, the bit I trust you're most interested in is how to use these guidelines and apps. There's an awful lot here, so we will launch straight into it. Firstly, the principle is what do you need to bring into the clinical situation to be able to use the apps? And that is that you need to have an idea of both the appearance and the mobility of the drum. A lot of eardrums can be done on appearance, and their mobility needs to be distinguished from normal for OME or other things like acute otitis media without perforation. So in the recommendations, we are suggesting both otoscopy or video otoscopy and either tympanometry or pneumatic otoscopy. It doesn't have to be video pneumatic otoscopy. The only advantage of video is you can show someone else, really. But we suggest, and the guidelines assume, that you know both of these pieces of information because it enriches the clinical utility considerably. So in the next few slides, you'll see a whole series of red boxes around part of the screen. And this will be guiding you through how to get to various parts of the guidelines. So we're going to run through quickly, firstly, the diagnostic algorithm. So here is what you do when you have a patient in front of you. So there is guidance on both diagnosis and otitis media. So we start off with otitis media diagnosis. And this, you'll have a picture and it'll say, is there a discharge in the ear? Yes or no? If you want to know where this sits into the actual clinical pathways, you push on this little algorithm and it brings up another screen. And then we can see down here is where you'll be heading from here in terms of the advice. Now, a lot of the time with the patient in front of you, you won't need this. And I suspect most people won't really be following these algorithms through from beginning to end. But it's just important to know that these screens have behind them algorithms that have been sorted out and nutted out by an expert group of people from different backgrounds and experience from across the country over many weekends and over many nights to come to a consensus situation. So what is new in the diagnosis? Firstly, we are considering in the diagnosis the child that has a discharging ear, tympanometry tube, The second thing is we've brought into these the idea that a critical point of decision making is when there has been discharge for more than 2 weeks, and this tends to trigger more the chronic treatment pathways. And we acknowledge that sometimes you won't have all the clinical information. So the child in front of you, you may not know how long the ear's actually been discharging, and where appropriate, that has been built into the guidelines. And then we have the fact that we will recommend drops when the perforation is greater than 2%. There seems, from an ENT point of view, no point if it's smaller. We have new guidelines now that will take you down what to do if there's otitis externa, because of course Indigenous kids get this problem too. Another issue that many of you will face is when there is unilateral hearing loss. And so here we see an example in this box where there is at least one eardrum translucent, which suggests that there is no sign of fluid. So how does that change your management? And finally, as we discussed previously, is that the eardrum mobile? Because if you know it's mobile or not, as getting right back to the beginning of the talk, you know the risk of there being a hearing loss much more certain, with a much greater degree of certainty, and you have a much greater degree of certainty about the actual diagnosis that you are dealing with. All right, so this is how these guidelines arose, and this is no doubt Amanda's kind of trying to synthesize the views of about 20 different people in terms of arriving at them. So now let's talk about the management of these guidelines. These were the guidelines in 2010, and they were based on children in high-risk populations, which really meant mostly children living in remote communities in parts of Australia. But as I said earlier, we acknowledge now that there is a need to consider children that may have a much lower risk who are still Indigenous, for example, many children living in urban places like Melbourne. So what are the differences here in these new guidelines? And what's the difference in the new guideline for the treatment of OME? Firstly, we have recommended, once again, concurrent referrals to ENT and to hearing. We've recommended that you document very carefully the presence of otitis media, so that we know how often this thing's occurring, and that there are strategies there to help with communication and support. But what exactly are we actually suggesting there, right, to help with communication and behavioural problems? And that is refer for the hearing assessment, refer for speech therapy, refer for paediatric assessment, refer for ENT assessment, and use and recommend strategies to improve communication, and to ensure that there's ongoing audiological language and education support. What's new here also is the inclusion of autoinflation that may actually help to resolve otitis media in some children. That's quite a change. There's the concurrent guidelines again. And then there's a specific emphasis on the hearing in the better ear, because of course, this is the overriding consideration for a child's disability as determined by the World Health Organization. And for also categorizing what to do differently when that hearing loss is milder, which is a hearing loss of 20 to 30 decibels, or more disabling, which is a hearing loss of 30 decibels or greater. So here is what that looks like, that same information. And you'll see then beneath there is a green little screen that will take you to what to do next, for example, if the problem is resolved or not. So what's new with acute otitis media without perforation? Well, here you'll be prompted to consider whether the child is at a high or low risk in living in a high or low risk environment, or the child's social circumstances might determine that. And there'll be different management for children in each of those circumstances. So what's new for recurrent acute otitis media? Again, the high-risk child. Here, the use of prophylactic antibiotics and the critical point being monthly review. What's new with otitis media with perforation? The option of a single dose of azithromycin, where that's going to be probably more reliable, or where you can't refrigerate the amoxicillin. And the use of ciprofloxacin-based drops for perforations of greater than 2%, and when this goes on for, and if the discharge goes for more than 2 weeks, to head straight to the algorithms on chronic serous otitis media. And so what's new with the discharging grommet? Well, absolutely all of it. And here we don't have time to go through all the guidelines, but it's all fairly self-explanatory. There are also guidelines on the diagnosis of hearing loss. And here the critical thing is, again, the division of hearing into normal, mild, or moderate in the better hearing ear. So the next thing is, how do you negotiate that screen? Well, if you push on hearing loss, you will then get what is relevant to that child. Here we have bilateral otitis media with diffusion for greater than 3 months. And then there is general advice, and then what to do if the hearing loss is in a particular category. So that you don't have to read those pathways. You can simply negotiate your way through this on the app. And next, and a really incredibly exciting part of this app is about communication. And these include audio translations for parents and children with otitis media. So if you go to that part of the app, then what you'll see is a whole series of things. There are key messages. There are audio available offline. You can actually make them online by pushing the button. You can select for various Indigenous languages the actual language. Unfortunately, there are none of the languages spoken by Indigenous Victorian populations. I'd love to see that change, and we'll see if we can maybe all together try to make that happen. But then there is the specific family messages, and you'll see here what the message means, and you'll see what it sounds like.
Untuk mayo tuinungodok tawal, pihak pilingang turwalalain wal tojak kaput toro yo tuinungo. Mak yo tono men mak yan nitunga tunduk tain wal tojak kaptan ngobot toro.
Right, so you get the idea. And you can see here that you know what the message is saying, but it's a way of speaking directly to the patient so that they can understand what you're trying to say. And I think this is an incredible innovation. Just moving on for time. So I'd suggest you have a look at that, and I think you'll find that a really useful resource to use on a day-to-day basis with your patients. There's also incredible education resources here. There's education resources for professionals and also for families. And here we'll see how that looks. So for the education for health professionals, there's an otitis media gallery where you can actually look at, if you choose otitis media, then you can see what a right ear with acute otitis media looks like. And you'll see there some images, you've got some videos of what that looks like. And again, if you're in areas where reception is a problem, you can download those resources. So the next thing you can do is to have a quiz to see what kind of knowledge you've got. So here we have, what are we looking at? The answer is correct. Is that the left ear? Yes, that's the left ear. And can you describe what you are seeing? There's a bulging eardrum. It gives you a description of what that ear looks like. So again, this is one way that you can upskill yourself in your own time. And for prevention, there are incredible videos and for children and for families. One is a simulation on the type of hearing loss, another one on general education on just health factors that will promote ear health, like blowing the nose, breathing and coughing. There's ones on just how hearing loss occurs. And we, again, won't have time to go through them all, but they're all there, and you can, with the family in front of you, take them through what is appropriate for them to know. Now, finally, we get to what's behind all of this, because behind all of this are the guidelines. Now, the guidelines are, it's important to know how we put them together and how you may wish to use them. I appreciate that many people may not actually wish to use the guidelines themselves, because the information is presented to you from the guidelines in these much more user-friendly ways. But here they are. So firstly, we used the GRADE approach to interpret the guidelines. There's an overview to otitis media. We have the priority children we've described, and there's a description of the art. So here's a list of the people, or some of the people, they don't all fit in the one page here, who actually contributed to the guidelines. And I can tell you that all of these people put in hours and hours of work. This is one of the most extraordinary things that I've ever been involved with in terms of just the input and the collegiality and the level of dialogue and discussion. But what is GRADE? GRADE is grading of recommendations, assessment, development, and evaluation. And that is how we actually went about that. And then what were our priorities in setting up these guidelines, and how did that determine the questions we asked? It is the children, and here we have the explanation of why the priorities that I went through earlier exist. And I've been through them, so I won't go through them again. But you'll see that these priorities not only tell you who's important, but they also determine for us how to go about building the guidelines. So the actual guidelines themselves, you can see what references and literature informed the various guidelines. And you can take you straight to PubMed to have a look at that. But this is actually how we went about it. So firstly, with GRADE, you start by asking an explicit question. And then from that, you include a specification of all the important outcomes in that. It provides explicit criteria for rating the quality of evidence that include the study design, the risk of bias, imprecision, inconsistency, indirectness, and the magnitude of effect. And when you're doing this kind of GRADE work, the recommendations need to take into account factors such as benefits and harms, an estimate of the effect size, the values and preference of the population, the cost and the health equity. Now, there's a lot of guidance online about how to go about this that is well kind of resourced and mature literature. GRADE in Australia has been recommended by the NHMRC for use since 2011. So we start off in the kind of questions, and it's important to understand this so you understand how to dissect through a question to what you're interested in, with a PICO format for asking explicit questions. And the PICO will start off with what's the population you're talking about amongst children here? What is an intervention? We'll show an example of probiotics. What is the comparator? Placebo versus no intervention. What is the outcome? The incidence in otitis media. It could be other things. And what is the timing for the of the antibiotic probiotic use? So here we have this specific example. So we go to the guidelines, we look for prevention of otitis media with hearing loss, and then we go down to the bottom of the screen, and we'll see strategies for preventing hearing loss with otitis media. We see here probiotics. And you can see here that we've come up with a weak recommendation for probiotics. And what happens is kind of the important thing to understand. So if we start off, the overall strategy is probiotics may reduce the incidence of acute otitis media. That's our question. Overall, the recommendation is weak. And what happens in children's receiving probiotics compared to placebo? There are probably fewer episodes of acute otitis media in 1 to 12 months at 3 to 12 months follow-up. We consider this to be the number needed to treat to be very high, of 17. If you want to see the actual reference, there it is. And then the quality is low and the effect is medium. So that leads to a weak recommendation overall. And then when you get to the summary of findings, this gives you more of a distillation of the findings concerning probiotics. And this is more of an articulation of how we go about assessing the quality of the evidence. And when it comes to outcomes, we can do exactly the same thing. Here's the references. And how do we use these for diagnosis? Similar kind of way of putting the information together. Here's an example of persistent otitis media with effusion. And here are the questions about what happens for the treatment of antibiotics for this particular condition. So it's for acute otitis media in high-risk populations or not. And here is an example for the antibiotics for otitis media may reduce the duration of otitis media. Give all children with persistent otitis media antibiotics. This is actually a weak recommendation. And there's the literature. And there's what happens and where the hearing outcomes. If we're now talking about hearing outcomes, we are looking for various, and you'll see here there are various outcomes we can look at here. Does this treat otitis media? Does it affect hearing outcomes? What about tympanometry tubes? And that's how you can use that information. So I think that's probably all we should do for this talk. If we're going to have any time for questions. So look, I thank you for your attention. I'm going to unshare my screen and we will take it from there.
Thank you so much, Professor O'Leary. That was fantastic. We're so grateful for your time and all of those tireless weekends that you, Professor Leach and everyone else spent creating this magnificent app. It's so great to see an approach that's so positively based in education. It has hope, self-determination and empowerment. It's really exciting.